rolling this strategy out at the AU by the chairperson of the African Union Commission, and we're looking for extended partnership to achieve those goals.
Number one that comes to my mind is the way that the Africa CDC has taken charge and is not only providing technical support to countries, and I know they've done that through training on testing and provision of testing kits, but also just on having the excess manpower that countries need coming from within Africa, because it's only people who can really understand the context in which they're working who can be effective in responding to any outbreak, whether it's Ebola or whether it's this. So I think the Africa CDC has really accomplished unifying African public health in a way that many parts of Europe and other parts of the world have not done so well. So I think it's really important that the Africa CDC be supported, along with the regional office in WHO, which provides the standards and the norms that are followed by the Africa CDC. So that's one reflection, that Africa is really taking charge of this itself. The second is that there have been many people from the north and from other countries who are saying why Africa isn't having outbreaks, this and that, when really we understand clearly what's going on now in Africa. We understand that there is a limit in the testing that can be done, and that certainly reflects on how many cases are being reported. But more than that, we also can see that there is actually an effort to understand this outbreak. And we know that people are dying. I think what's encouraging to date is that there aren't clusters of deaths being reported from African countries, as there have been from many European and other countries, which suggests that, as John said, Africa is still early in the epidemic. It's still early in the epidemic curve because it didn't arrive there as rapidly as it arrived in other countries. It's also very important that, and I know John has been working with this, making sure that the Chinese collaborations and the North American and European collaborations are collaborations which aren't bringing in the disease from those countries, but they're working in conjunction with the collaboration mechanisms in Africa. So I would just say that the reason we know now what's going on in Africa is because of the great effort and the great coordination being done in Africa by the Africa CDC. And I would just say it's really a pleasure for me, having worked in Africa 30 or 40 years ago, to see how Africa is really taking charge of this on its own. So Emma, back to you. And again, thanks to John for having come and met with us today.
Thank you, David. John, I did have a follow-up question on the graphs. The curves that are diverging and showing a variety, that's based on cases reported. I just wondered the relativity between the countries. To what extent is that down to the differences in the testing capacity, or at least case finding, rather than real differences? Is there a big variety in the case finding capacity between those countries that may be showing up in the way those lines are showing up on the graph?
So, very good question. And that's why I said in my presentation that I wanted to draw your attention to that, and then that will at least lead to this kind of a reflection or questions. I think there are two things that, two ways of looking at that. First is that countries that you see them deviating upward are those that are doing more testing. And as I've always maintained, if you test, you'll find. And then secondly, is that countries that are not, that are doing, the other countries that are on the bottom part of each of this slide are those that are doing less testing there. I think we don't have evidence for that. I mean, we actually, of course, know that South Africa is doing a lot of testing. We also know that countries like Botswana, Namibia, Zimbabwe are doing a lot of testing, and I mean, as well. So I think it's a mixture of that. I think it could be a combination of that countries are testing more now. Nigeria, for example, you saw the testing per million. Okay, the number of testing is increasing, but it's not it's nowhere near to where it should be for a country of about 200 million. So my short answer to that would be that it's a combination of two things. Either we are seeing testing playing a role, or that we are just see some of these countries doing the best at testing, isolating, and doing the contact tracing there. So that, again, by doing this kind of analysis, it begins to allow you ask the next set of questions as to what are they doing that is keeping their curves a little bit slowly, evolving slowly, versus those that are very prominent there.
Yes. One thing one more thing on that. If it is down to differences in testing, obviously, the more you test, the more cases you find, the worse your epidemic looks relative to others who aren't. Are the countries comfortable with being shown to have high numbers, or relative to others? Is there any sense or any reticence to show high numbers? Because I would imagine it's something to be applauded and supported that they test, rather than look better by not having as many reported cases.
So with rare exception, I can say that the continent as a whole is reporting and reporting accurately as best as again with rare exceptions. You can imagine that your knowledge of Africa is as good as mine, that we are dealing with 55 member states, and the behaviors at times will tend to differ. But again, overall, the behavior in patterns of reporting of the cases have been characterized that as a very good response. We still, of course, have a few countries that we are challenged with, but I would not think that those countries, even if you one or two countries or two or three countries, that would change the overall pattern here of the behavior of reporting. So it has been a good cooperation, which all the countries signed on. They signed on the 22nd of February that we will cooperate, we will collaborate, we will coordinate, and we will communicate.
Thank you. On the delayed epidemic, high numbers of deaths were expected in Africa because of fragile health systems and inadequate access to preventive measures, etc. But the continent appears to have so far been relatively spared. The scale of the outbreak that we've seen in other places, if you go by the number of, obviously we've discussed the testing situation, but surely that can't explain everything. Do you have any thoughts as to why that is? There seem to be many hypotheses floating around, but what's your view as to what might be going on there?
So, and again, I'm happy you say my views, because there is no evidence that or scientific evidence yet to back any of the things that I would say, and it can only be a hypothesis that would definitely lend themselves to a good studies that will analyze this. I think we are early on. This is what, 4 or 5 months into the pandemic in Africa, and as we used to say in HIV, you have to know your epidemic to respond appropriately. In this case, we have to know a pandemic on the continent, and we will be doing studies across, of course, as a network of countries to understand some of the reasons there. But a couple of thoughts. I mean, one is that a couple of views here, and one is that because of the young population we have, that might be playing a role, favorably role for that works in our favor for mortality. I was on a seminar with Kenya about 2 weeks ago, and it was interesting to hear the officials there stated very strongly that they have so many young people or people that are running around with COVID infected, but they are not sick. They are not. And they said, in quote, large number of our people are running around and they are not sick. They are positive, but they are. So I think that could be one hypothesis to investigate. I think, but again, good studies would need to be done to really understand this and be and to make statements that are backed by evidence. Second hypothesis or view is that we may not be seeing recording all the deaths that are happening in the community. That is possible. Is all possible. But if that was the case, I think mortality in, of course, surveillance in Africa is not as strong. But deaths are taken seriously on the continent. You will hear if there were a large number of deaths occurring, like what we understand has been going on in some parts of Nigeria, you hear that. Okay, I'm in Ethiopia, and I've not, with the media or social media or others, based on event-based surveillance, is not telling us that large number of people are dying in the community and that we are not aware of, and that is true across Africa. And so I think those are the only two possibilities that I can think of, but only good data.
Which is quite young. And I think the second thing is that they're just not able to identify clusters of death, which has been the indicator in many countries. And it's what derailed many of the good epidemiological approaches in countries in Europe to go immediately to a mitigation strategy and abandon this test, trace, and treat strategy, which Africa is putting in place. And so I think that we can see that Africa is observing what's going on, is learning from Asia and from countries in Europe like Germany, which continued contact tracing and testing throughout the efforts to decrease the burden on hospitals. And it's been effective in those countries that continue it. So I think Africa is showing that it has seen, and John, you might correct me if I'm wrong, but that you've seen that this disease is not like influenza. This disease can be stopped in outbreaks. Discrete outbreaks can be contained if you do the proper contact tracing and isolation procedures, and you can interrupt a whole new series of chains of transmission which might occur. But again, John, you can correct that if you feel differently on that. Over.
No, David, we feel strongly about that, and that's why we put up this strategy, and which we really want to applaud the leadership of the continent. Not just the technical leader, the political leadership of the continent has been very, very strong. The President Ramaphosa, the president of South Africa, has been leading in his capacity as the president of the African Union, has actually moved this strategy to the Bureau of the Head of States, and they endorsed it. So this has been endorsed at the highest level of the continent based on the advice that the task force has given them. I think this is unprecedented, that the head of states that I've had the chance to briefing them about 4 times have adopted and endorsed this strategy. We call it the winning strategy, because we don't have a vaccine for this. I think we will, if we are lucky, we'll have a vaccine after 1 year or so. We don't have treatment. So we are really left with the ability to test, expand our testing, trace, isolate, do the basic public health functions that, I mean, we all know called a standard shoe leather epidemiology. That is our winning formula. And that's why we are calling on 1 million community health workers to really be deployed across the continent. And we at Africa CDC will begin to increase that as much as possible. And as we launch or roll out the strategy tomorrow, it would really be, we hope, can be a game changer, so that when they test, they can actually trace and isolate and do what is required.
Thank you. I wanted to ask you about previous efforts to strengthen public health capacity and health emergency preparedness in Africa. This has been pledged and committed to several times, most recently after the West Africa Ebola epidemic a few years ago, all the review panels and the commitments to strengthen capacities in Africa. How much of that was actually done, and did those efforts help better equip the response for this pandemic? Are you seeing any of that stuff coming through and playing out in your ability to tackle the pandemic this time?
So the answer to that, in my view, is yes and no. The yes part is that if you look at, excuse me, Liberia, Sierra Leone, and Guinea, after the Ebola outbreak, we had, they strengthened their national public health institutes, and they know how to do community engagement, because all of what we just discussed earlier, the battle for COVID in Africa will be won at the community level. I mean, period. I think we need that cooperation, we need that collaboration with the community. And those countries in West Africa there with Ebola really understand how to engage with the community. And I think we are seeing that in Liberia, Sierra Leone, and Guinea. You're also seeing that in DRC, because DRC has been battling Ebola. I mean, as we speak, you're all aware, you have 2 outbreaks going on there, and that community engagement approach would yield a lot of benefits there. So I think that much Africa has been can use that expertise, and also the expertise in and the experiences battling HIV. The way South Africa could, the reason they were able to move very quickly, and there's still a large number of people and employing the community. I think they currently have about 28,000 to 29,000 community workers supporting their efforts. Is their HIV experience, their vast HIV experience there. So it's something that the continent has been primed and can use. The no part of that is that we are still really lagging behind with respect to the number of the public health workforce that is required. And we did Ebola in West Africa in 2014. It was, everybody knew that the number one gap that we have on the continent is the number of frontline epidemiologists or the epidemiologists. As the number states, I mean, we are a continent of 1.2 billion. We need about 6,000 epidemiologists. Let me just restrict that, not even looking at the entire spectrum of healthcare workers, like the lab, the nurses, and all, just epidemiologists, 6,000 are needed. We currently, the numbers that the Ebola outbreak in West Africa, that says, let's train a large number of frontline epidemiologists in the way that you train an army when you are reconstructing Afghanistan or Iraq. I mean, we just didn't go to Iraq and Afghanistan and started training 10 cohorts of 10 that we went in there massively and trained a large army. That's what we should be doing in this health security space, where we really say, this is serious, this is devastating. I keep telling the AU that this virus is a dangerous, vicious threat for the continent. It took us 40 years for HIV to infect 75 million people. It's taking us 5 months for the world for this virus to infect close to 6 million people, 5 months. So, I mean, if it spreads this way, then I think we really will need an army of people on the continent to of public health work. But that is a gap right there, which I don't think that previous pandemics or outbreaks have helped us to bridge that gap at all.
David, is there anything you wanted to add?
Yeah, I might just add a little bit. You know, there's a global preparedness monitoring board, which has been set up under the leadership of Gro Harlem Brundtland, who used to be the Director General of WHO and Prime Minister of Norway. And with a group from Oxford, Chatham House in Oxford developed a background paper for them in their first report on monitoring preparedness. And what our conclusions were is that the governments in the North are still trying to spend money on developing capacity in their own countries to respond to outbreaks elsewhere and setting up global mechanisms, whereas what they need to do is exactly what John has said, strengthen the capacity in countries so they can detect and respond when and where infections occur, not wait for an outbreak to occur and then for a team from the North or from somewhere else to come in and try to stop the outbreak with them. They need to have that capacity, and we need to begin to change our thinking from we will do it for you to we will help you strengthen the capacity to do it yourself. It's a very difficult mentality to change in many countries in the Northern Hemisphere, where their idea of global health security is defend ourselves by setting up mechanisms that can stop diseases from coming in, rather than strengthening the capacity where and when diseases occur. So I think there is a shift going on. I think the Global Preparedness Monitoring Board has emphasized that needs to happen. And I think groups like the African Union and Africa CDC can make sure that that happens by making sure that the international development community understands that it's no longer you come in and do this job for us, you come in and train us to do the job, and we'll do it for you and keep these diseases from spreading wherever they might spread. So that was what I had to add on to what John has said. And I think it's a very important message that countries begin to understand that it's no longer we do it for you, you do it for yourselves, and here's the way we will help you strengthen that capacity.
Thank you. I'm going to move on to questions now, starting with one from Mark Malloch Brown. How is the CDC Common Pan-African procurement of PPE, etc., going? And second, what is the division of work with WHO Africa? John.
Yes, no, sure. I just wanted to be sure the format you wanted is to do a question by question or take a pool of questions.
Oh, no, I think we'll do question by question, and then I might do two the next one.
Okay, well, whatever formula. So I think that the pool procurement mechanism is going extremely well. As we speak, in the next 1 hour, we, the chairperson of the African Union Commission, that is again one of the strong coordination component of this pandemic response that must be highlighted. We'll be hosting a meeting in exactly 1 hour's time where all ministers of finance and ministers of health are coming together with the special envoys that the chairperson of the AU, President Ramaphosa, appointed, the Ngosis, the Donna Kaburuka, and others, to present the platform that we just developed, okay, with the support of the private sector, which will be like Alibaba.com or Amazon.com, where you can go in there and pull things and put into your basket and pay. That will ease, begin to unlock the process of supply chain management that has been a big problem for us. I think that is really, I'm excited with that. It will be presented today, again, in the next 1 hour that will be done. I'll give them an overview of the joint ministers of finance and health. The ministers of finance, because of the debt relief, the debt standstill, and other mechanisms that the World Bank, IMF has made available to the countries, the money is there, but we need to bring them together so that the ministers of finance and health shake hands and agree that they will buy this, they can release the money to buy these commodities that are so important. If they have to unlock the economy, you have to first of all stop the virus. I think that is, so we are very excited with that. We will see how it goes. There are about 5 countries already that are prime up to start using the platform already, and it will be officially launched by the Bureau of the Head of States, headed by President Ramaphosa, and of course the chairperson Moussa Faki next week. So I think that is that. With respect to the division of labor with WHO, we are in very close contact with the WHO in the 2 regions, with the Afro and myself and Dr. Moeti Chidi, a friend for many years. We talk very frequently, and just as of yesterday, we were also talking about the Ebola outbreak in DRC, the new outbreak, and we will be jointly issuing guidelines for the serology testing on the continent and many other aspects that we have. Again, the task force that I presented is a continental task force endorsed at the highest level of the continent. So we are all part of that continental structure, which was launched on February 22nd with the presence of Dr. Moeti and Dr. Tedros calling from Geneva for the first hour of that meeting. So we are coordinating and linking up as much as possible.
Thank you. This is a question, a most upvoted question from Louise Hart. Is there any evidence so far that the trajectory of the outbreak in countries in Africa is differing from the way it has developed elsewhere in the world? And I think you can both probably have something to say about that. So
maybe I'll start. Maybe I'll start, John. Yeah. I think that as John said, this is it's relatively new in Africa, the outbreaks. They didn't come in as they came into Europe early in January, February. And so now it's coming in and they're beginning to understand. And interestingly, in South Africa, they've shown that it's come in from Europe and not from Asia. So I think it's beginning to enter into Africa from many different places. And Africa is now setting up the mechanisms to really deal with it. So you know, that's the first thing that I wanted to say about this, is that it really is young, and Africa's beginning to respond the way it is, and it's coming from many different directions at the same time. What's the next part of the question, Emma?
It's whether the trajectory of the
Mhm.
disease in Africa is behaving. Is it going the same way as it has anywhere else, or any evidence that it's different from the
Well,
way
I'll just
it's
speak,
developed
yeah.
elsewhere?
I'll just speak from what I know about discussions at WHO with various countries. The trajectory in South African could have been just like in European countries. It began, but they rapidly went out to their health facilities. And as John said, the local response is what's really effective in many places, including Africa. They went out and they strengthened the capacity in their primary healthcare facilities. And then they saw the outbreaks shift from a European population that had been brought it in, and the populations in the major cities, to areas in rural South Africa, but they were able to contain those outbreaks as they were occurring. So the trajectory, at least in South Africa, was the same. And I think that's why John can speak better, but that's why I think this test, trace, treat strategy is going on now in order to prevent this, the same way that South Africa's prevented it from taking off in that part of the world. So back to John, I guess, for his observations.
No, I mean, David, you're absolutely right. And this is, again, not an area of speculation, but we're back with data, because when countries went into lockdown very early on in March, it was interesting that when we left Addis Ababa and agreed to develop a joint continental strategy on February 22nd, only Egypt had reported a case. And when they left, by the end of the month, exactly, I think 29 or 28 of February, and Nigeria started reported cases. And then subsequently, the first week of March, I would say, I use this very deliberately, the continent tip, because so many countries reported cases from Europe coming in there. But then they did something extraordinary. The countries were locking down where they had 2 cases or 3 cases. Some countries went to states of emergency where they had no cases. And so that helped to blunt that. We have data that shows that South Africa, for example, was seeing a daily increase in number of cases, about 30 to 40%. And with the lockdown after 2 weeks or 3 weeks, it had decreased to about 5% increase on daily basis. So we have enough data to support that helped to blunt the outbreak. Otherwise, we would be in a very, very different situation. Now, the challenge we have is, as countries are unlocking themselves, we have to provide guidance, and which we've just developed guidance for unlocking our economies, and which is really a balance between saving lives and saving livelihoods. And we'll see, of course, in the next coming weeks, what that will look like, because as we unlock a system, there will be, it's clear that we'll see an increase in number of cases. But the key question will be, are we doing the test, trace, and treat strategy in an enhanced way? And also, have we used the borrowed time that we had to increase our healthcare facilities to receive more patients? Have we learned some new lessons that we can apply there? So I think I don't know many of those answers. As David said, we are dealing with a new virus. We are learning every day, and we are trying to understand our pandemic as much as possible.
This is another one for you, John, I think, from William Crawley at the BBC. Is the disproportionate risk of infection reported among BAME communities in UK and USA specific to those countries, or is it reflected in the African statistics as well?
To be quite honest with you, we have not done a continent-wide analysis. And again, as I said at the start of this, the continent itself is so diverse. And that's why I took time off to go region by region, and we see them. It's very misleading to dump numbers on the continent. It will give you a very different picture. So that analysis is beginning to happen. It couldn't have happened earlier because the confirmed death number rate was low. Excuse me. And as we move with this large number, countries are beginning to do their own analysis, like South Africa, to understand what are the groups that are most vulnerable and what are the underlying factors that are driving mortality. And again, it's too early, but some of the initial trend shows that people with existing diabetes, hypertension, have seen a higher mortality amongst them, as well as HIV. I think that, as we would have expected, that is, but again, it's very early. We still have to pull this data together, work through as a task force, continental task force, to analyze and understand this data a little bit more.
Thank you. Here's a question that we've kind of covered. This is about from Yasser Abdul. It's an upvoted question. What would you say Africa is doing well that European countries and others could learn from, and vice versa? We've discussed the regional approach seems to be quite this unifying approach. But David, why don't we start with you of what you've observed Africa doing that European countries could learn from?
Well, I think that, everybody, thanks, Emma. I think everybody is striving to equalize the risk and equalize the response capacity so that international travel and trade can begin again. In other words, countries with the same risk and with the same capacity to respond will be those countries that can be fairly well assured that if they open up their travel and trade, they will have the ability to they will not see an increase in cases in their countries. That requires a good disease detection system. And that's where Africa may have difficulty at present, but they're strengthening this capacity to detect this. And certainly in capital cities, they'll be able to detect where there are cases that are occurring so they can rapidly respond. Where Africa has in place a system to respond is much better than in some European and other countries. This track, test, trace, and treat mechanism, which is vital to being sure that there is a response capacity so that when risks are equal, the response can be occurring if necessary. And so I think Africa will be possibly ahead of many countries in having this ability. They already have it from outbreaks of Ebola, outbreaks of meningitis, whatever they have to deal with, they already know how to do this. Contact tracing, trace, test, trace, and treat. So they're way ahead in that. They may not be ahead in disease detection systems, but I know that they are working under the African Union, under WHO, to make sure that those systems are in place and can be reporting when there are diseases that might be COVID, for example. So that would be my views, Emma, and I turn it over to John now for his views on this.
I think, David, there are two components to this. We had the great fortune of seeing what was going on in China, Europe, and the United States, and use that to argue for a strong, coordinated continental approach. I think, which again it was exceptional that within a week of the first case being reported in Egypt, the continent came together, and that continental mechanism still exists. Every week on Mondays, ministers from the different regions all come together, about 15 or 20 of them, and we discuss this together for about 2 hours. I think that is a very good thing. And I've said that you also have ministers of finance coordinating and transport, and that all fits into the bureau of the head of state, chaired by President Ramaphosa, and with a strong coordination of Chairperson Moussa Faki. So I think that is good. There's a difference between knowing what to do and having the ability to implement what you know what to do. I think that is clear. If our pandemic goes out of hand, it's not because we don't know what to do. It's just that we are limited with a capacity to implement what we know to do. And I must say very personally that to me is very, it stresses me more than anything else. I think that, that if you see the challenge we had in getting diagnostics, okay, in saying supporting Chikwe or supporting Amadou Sarr or supported Victor Mukonka in Zambia to get access to tests. I mean, you called and said, John, we have 5 swabs, okay, to do the testing. This was very early on. And then what do you do? So I'm scratching my head, looking across the whole world to find additional swabs to send to Zambia. So you ask yourself the question, if we have those, we knew what to do, and if we had those commodities to respond, where would we be? Okay, so I think that is something we must factor into the discussion when we think we do an after action review of how our response was. I mean, that I really will hope that it should be central stage in the discussion, and how do we fix those gaps? What I call the known do nothing gaps. And on the continent, some of that is on the continent itself. We have to evolve from a continent that says we must manufacture certain things, like diagnostics. We have to have platforms that can manufacture diagnostics on the continent, such that you don't rely completely from external supplies for diagnostics that you could. I mean, I'm happy that the Senegal group is developing that. Morocco is developing something. I believe South Africa and Kenya are doing that. And we are at the center as Africa CDC, helping to coordinate that manufacturing process and evaluation process there. So, yeah, I would say that, I mean, there's those gaps that existed, which there's a lesson for Africa to learn early on, and hopefully that the world is learning something from Africa.
Following on from that, actually, and I think you partially answered this, 2 questions from John McDermott from The Economist. And the first one was, what needs to be done to get tests to Africa? What are the precise bottlenecks? You've discussed manufacturing capacity and the reliance on importing, but is there anything else that is specific, a precise bottleneck in testing capacity? And the second question is, is the CDC doing anything to try to measure excess mortality rates, which are viewed as the gold standard way of measuring the impact of COVID-19? Many countries don't have cause of death data, but is it possible to do samples in hotspots? So if you want to answer the bottleneck in testing first, maybe.
Yeah, the bottlenecks in testing, as I indicated when in my presentation, it was it continues to be a challenge, but something that we should look at the trajectory we are heading to. Just about a few weeks ago, really weeks, I mean, the continent was testing had tested less than 400,000 tests. And now today we are about 2.4 million tests, and the curve is in the right direction. I think when we fix and we address issues, we don't expect that the solutions will